physiology topic that we're going to zoom into is going to be the renal physiology and the fluid balance, electrolyte balance. And we're going to cover a couple of topics, and I'm going to hit on these and just make sure that they are clear as you progress through this chapter. So clearance, we're going to go over micturition, which is the reflex of urination. And then, of course, the body's balance of sodium and water. That's, if anything, the most important regulated aspects of the kidney. And then, of course, the thirst and salt appetite responses. So what you have is you have this equation that we alluded to a while ago called clearance, right? And clearance is a way to measure how much of something is cleared from the body. And it's expressed in milliliters per minute, so it's pretty standard. But I want to reiterate how to get to that equation. And I had a question on Wednesday through the discussions that the U, or the first variable in this clearance, is the amount of the concentration of whatever substance you're looking at in mg per mLs found inside your urine. You then take that concentration amount, so it's the amount of something, times it by the volume, or sorry, the V, which is the flow rate of the urine formation, so how quickly it's generated, because it depends on how well it's either being processed. So it's also expressed as milliliters per minute, and then over the amount of that stuff inside your plasma. So how much of it's still in your system, right? And the question we had on Wednesday was, we talked a little bit about inulin. Inulin is not insulin, right? So this is a key term to be aware of. But inulin is a chemical that is freely filtered and is neither reabsorbed or secreted. And so previously they used a chemical compound called creatinine, which is found in muscle breakdown. But this is a lot more better in assessing your GFR and your kidneys function. So just be aware of this relationship and what is in the equation. So let's put some numbers together and give you a feel for how to visualize this, right? So what you have is, if you use inulin, you can look at the amount of concentration of inulin inside the plasma. So let's say you have an arbitrary 4 milligrams per liter of this chemical in there. And like I said, inulin, for those that don't know, is a fiber. It's a dietary fiber that you can't break down with enzymes. And so as it gets into your nephron, it's going to get through into the glomerular capillary. It's going to be filtered through the Bowman space. And eventually, you're going to be able to draw out a specific speed, a GFR of about 7.5 liters per hour. You take the concentration of what we just had over there, 4 mg per liter. You times it together, then you get a total amount of how much is actually excreted. So you have roughly about 30 milligrams of that chemical coming out per hour. So you can assess most chemicals and drugs and to study how long it takes for the body to process it, right? And so as a result, certain drugs and chemicals that are therapeutics will have a certain range of their action. So you take a drug after the first meal, and you got to take it within another 3-4 hours, because a majority of that chemical is then excreted out of the body. So just be aware that there is no absorption of the reabsorption of inulin, and there's also no secretion. It's all completely filtered. So it really measures your filtration rate. So another subtopic in this module is going to be on the whole process of micturition. Micturition is kind of a way to look at how the urination reflex occurs. And as you're probably all aware, we have the autonomic nervous system, the parasympathetic, and the sympathetic somatic motor neurons that play a very important role to control the muscles. They control a small muscle called the external urethral sphincter. Right? There's another muscle called the internal urethral sphincter. The internal sphincter is the one that is going to be involuntary control, whereas the external urethral sphincter, to some degree, you have a little bit of conscious control. And as the urine drains down through the ureters and goes through the urinary renal pelvis and down to the bladder, it's going to eventually start expanding your bladder. Your bladder is filled with a ton of baroreceptors, and that picks up stretching and tension. And eventually what happens, your bladder feels that discomfort, right? You're going to feel, oh my God, there's a little bit of pain or ache in your bladder region. And it's going to expand to the point where now the nerves begin to fire to cause the muscles to begin to relax. So this micturition reflex is initiated by a series of nerve impulses coming down from the sacral lower region down to the actual muscles. So when you look at the way the parasympathetic and sympathetic control this, you can divide it into 2 sets. One set is during the filling phase, as the urine is draining in to your bladder. And then you also have a phase where you actually begin to urinate, all right? And so what happens over here is, this is just a cartoon picture of a bladder, and you can see it can extend up to over 1,000 mLs of urine. It's super discomforted at that point, but on a on a normal amount, about 400 mLs of urine, you're already having the urge to want to pee. And so just imagine how much fluid is sitting on top of this, and you have that pressure point trying to drain out. And so there's two phases. We have the filling phase, and then we have the micturition phase. So let's go with the filling first. So filling, what happens is you have a smooth muscle that surrounds the entirety of the bladder called the detrusor. On the bottom end, inside of it, you have the IUS, internal urethral sphincter, and then on the bottom end tip, you have the external sphincter. So the external sphincter is the one you can, to some degree, control, right? You have that aspect of trying to hold that in, and that way you don't have an accident on your pants. But as you get older, or as you have incontinence, or if you have some kind of drug, you might affect the bladder's ability to do that. So the IUS is the one that is under most of the involuntary control. Right? So just be aware of which muscles play what role. So during filling phase, as you're forming urine, what happens is the parasympathetic division begins to inhibit the smooth muscle. So then it causes it to not actually allow it to contract. And then whereas during the micturition, when you're trying to pee and urinate, the detrusor will be contracted, and it will stimulation to allow you to squeeze a little bit. On the bottom end, the IUS, so this is the first door, this is the very first door, internal sphincter that you can't control. During the filling phase, it is stimulated because you want to close it so that you don't have urine leaking out. But the moment you begin to urinate, right, it makes really clear sense, is the door is going to then open up so that you allow urine to come out, right? So then, of course, it's inhibited during micturition. And then the last part is then the somatic one, which, as you can see, in most cases, you have some slight control of it, but when you are filling and as the urine is piling up, the somatic motor neurons are going to be stimulated to help you maintain it being closed. And then, of course, when you are allowing you to urinate, it's going to open up so that the urine can come out. So just be aware that it's a couple of control systems, right, to ensure that you have a management of your urine. You don't just, leak urine out. But as you get older, or as you go through certain kinds of diseases or drug treatment, it could weaken some of these nerve signals to the muscle. And that is also why, you probably even heard of kind of a saying that when you are, having a full bladder, it makes you begin to feel almost very discomfort to the point where your body starts to react, to that discomfort. And I remember reading one of the articles that compared this to drunk driving. It's like when you are at a point where you need to urinate and you can't, and you're driving, you become a lot more risky in terms of your behavior because your body's control system is kind of confused. So overall, you can see that in an average daily life of taking water or food. And again, the quote is the average daily water intake and gain and loss for adult male could change based on your activity and what kinds of food you're eating. But in general, if you want to put some numbers here, the input in liquids, you're drinking water, you're eating your 3 meals a day or 4 meals a day, and you're relatively metabolically active, so you're moving around a little bit. You have these numbers, and these are just estimates. So liquid, you have maybe about 1,400 mLs of fluid through just water or juices or coffee. And then through food, you're eating some salads or vegetables, 1,000 or plus so of mLs of fluid. And then your metabolism, you're generating some 350. So you have about an intake of about 280 or so, 2,800 or so mLs of water. And then as you're breathing, as you're sweating, as you go through the defecation and urination phases, you're going to lose some fluid. And you lose roughly about 2,800. So there should be a balance with how much goes in and how much goes out. And that's also why you try to consistently take in the amount of fluids. So sodium is also similar, right? So that's why there's a daily intake of what sodium is acceptable. But you'll see from all the kinds of foods, depending on if you eat more prepackaged food or if you're cooking your food, you might have a higher intake of sodium, but somewhere about 8 grams of sodium altogether in one day. And then the output, including sweat, fecal matter, urine, roughly equate to about 8 grams. So there should be a relative balance to the input and output, right? So that's why you don't want to overly salt your food, but at the same time, if you are physically active and sweating a lot more, it's good to be able to take in more sodium. So altogether, what makes this module interesting in the regulation phases is that when there is changes to your water or changes to sodium, your body begins to react, right? And this is a nice map that ties a ton of the different concepts we talked about over these past couple of weeks from the cardiovascular system. So the story begins, and you remember where, let's say you have water loss or sodium loss because you're sweating crazily, or maybe in this case you have diarrhea. You got the stomach flu and you have diarrhea. Now you're losing a ton of water and sodium out of your fecal matter. So the very first outcome is you have a drop in blood plasma level. So this is what I would like you to think about when you ration out what's happening in the patient, right? So the very first thing is when you're losing water, you're losing blood plasma. So the volume of blood is going down. So as a result, then the amount of blood going back to your heart, your venous return, is going to be lower. That's going to trigger several things. Number one, on the far right, the amount of blood going back to your heart is going to be lower. So you have number three. That will then decrease the amount of atrial pressure going down the heart. So you have less ability to squeeze the blood around, right? So that will then obviously link to a drop in the end diastolic volume. That will then cascade down to a drop in stroke volume, and eventually cardiac output is going to go down, right? So now you remember cardiac output is equal to stroke volume times heart rate. So somewhere along the way, the heart rate has to go up. So this person's heart rate has to go up to help you take away this entire imbalance. And then on the far left here, you'll see because your blood pressure has dropped down so much, some of these nerves are going to pick up signals. The baroreceptors are going to pick up the signals. Less blood is going through the brain and through the aortic arch. So the sympathetic nerves are going to then fire up, and particularly the ones going to the kidneys. So this is what's going to happen then. So inside your renal tubules, inside the nephrons, it begins to constrict the afferent arterioles like crazy. So it holds it down. So instead of having so much blood going into the kidneys, right, you're going to then block as much entering of blood into the kidney so you don't lose it, right? You're going to try to constrict the afferent arterioles so it decreases the GFR, decreases the glomerular filtration pressure, and you hopefully drop down any more loss of fluid. Okay, so this is the thought process that I think would be really nice only in a map form to make it very clear when you see a patient, when you look at pathophysiology, it's always starting with some sort of a stimulus or some kind of a trigger, and oftentimes this could be disease related. And then what are the outcomes to the patient? What happens immediately and what happens right after? Okay, so I hope that makes a little bit of sense. So this is another way to look at it. So let's say you're severely sweating, right? So you're sweating so much, you're outside in the heat, it's 100 degrees, and you don't have any water, then the sweating is going to cause you to have a loss of the hypoosmotic salt solution and a super salt solution in the body. So you're losing salt. And as a result, just like we said, is you're going to obviously lose the plasma volume because the water follows. And then, or you could also have an increase of osmolarity, which is the stuff in the blood because you're losing water, right? In two of these scenarios is the same thing. So your body doesn't just discriminate between how it sees it. If you lose blood, both water and salt, right, you are losing blood volume. But if you just lose water over here and you're still having the same amount of salt, just water is being lost, then that means whatever blood you have left on the right-hand side is super concentrated, right? Because it has less water to fill it out. And so in both scenarios, what happens is your body's then triggered. So the first part of the story, what I want to highlight, is on the left-hand side. When your body goes through a drop in both sodium and water and an entire plasma volume, obviously your GFR goes down, and then what happens is your body utilizes aldosterone more. So aldosterone tends to be the one to help compensate the ions and the water. Whereas if you were to just lose water and not the sodium, so sodium is still preserved over here on the right-hand side, so you still keep the sodium over here, then what happens is your body relies more on vasopressin, okay, so which is ADH, right? So just be aware that the trigger might be a little bit different, but they are really closely related and they coincide, all right? So last but not the least is thirst response, right? So when you think about your body losing water, being dehydrated, we all been there. We don't drink enough water, and usually when I go over this part of the lecture, people start drinking water in the classroom. They for some reason, start getting their water bottles. They start drinking water. But the whole point is controlling thirst is also a really important trigger in the body. Number one here on the far left is the very first trigger is when you have a drop in blood plasma volume. Or like I said, you have a loss of water, but you're still maintaining the concentration, so you have an increase of osmolarity. And then you might be eating some foods that just tend to dry up your mouth, right? Makes your tongue a little bit more dry. Maybe you're eating a handful of nuts, and then maybe you're not drinking any fluid, so you get this dry mouth irritation in your throat or your mouth. And of course, let's just say you are changing the amount of water output from the GI system. So all of these are going to cause the receptors, whether it be baroreceptors or chemoreceptors, to pick that change up, and they'll trigger your hypothalamus to have that thirsty response. So you have that cotton mouth feel, and you want to have some drink. But there is also some studies that have pointed out that angiotensin 2, this vasoconstrictor, could also impact your body's thirst response. And so when you're coughing or when people have very bad cases of COVID, there might be also some sort of disturbance to their ability for being, really thirsty. I don't know if that's been documented, but because there are some receptors for that thirst center in the hypothalamus, maybe there could be an effect because of this. Okay, so this is just a map to kind of highlight all the different factors and to make it very clear. So to kind of wrap things up and to summarize all these really cool concepts is there are a lot of clinical applications. And this is a nice little touch because a lot of you guys are starting to work on the case studies. And as you probably are aware, I try my best to make this course as clinically relevant to you. So most of the students are going to nursing and health fields. And understanding the physiology is directly linked to understanding how the body works and the drugs and treatment options. So for the kidneys and renal function, there is a family of drugs called diuretics. And there's actually 4 types. But diuretics are going to be substances that favor the ability to lose water and also sodium because you are at a situation where your blood volume is too high, right? So think of hypertension, right? So you have too much blood volume and you don't want to risk damaging the blood vessel and the heart. So you have to be using certain kinds of prescription drugs that are going to act on the nephron tubule to help you change the way the sodium is absorbed. And they're very specific because this family of diuretics are so specific that they can be used not only just for treatment of hypertension, but some people might even abuse it to lose weight. So as you probably are aware, alcohol is very similar to a diuretic. If you go out partying for a night and the next morning wake up, you'll realize you're urinating a lot more. And the urine is very clear because your body is drawing all the water out. But if you didn't know that, the alcohol actually will act on the brain by inhibiting the release of ADH to some degree. So therefore, what happens is your water in the body isn't being reabsorbed in the kidney, it is coming right out. So whatever you drink, all the fluid is being secreted and excreted right out. So the first class of the diuretic that you might hear about as you go into your nursing program or go into pathophysiology is one called osmotic diuretics. These are going to be salt or sugar solutions, oftentimes that are carbohydrate based like mannitol. And then these ones are the ones that are filtered out but not reabsorbed. So you put it in the body, it helps you draw the water because of the osmotic effect. So it chases after the sugars inside the tubules. The second class of the loop diuretics that you might hear about are called, I just said it called loop diuretics, and the most common one is called Lasix and furosemide. These are the drug names, by the way. Extremely powerful because they actually inhibit the ability for most of the sodium reabsorption to occur. So they block the channels directly. Another one you might hear about is called hydrochlorothiazide. These ones are not as potent, but they are the ones that specifically act on the DCT. Of course, also regulating the sodium and water uptake. And then we also have aldosterone antagonists. So this is probably one of the first times I've talked about a drug antagonist, but antagonist is a drug that blocks something. So spironolactone is a classic drug name, but they call it aldosterone receptor antagonist, also known as ARBs. They oftentimes call these ARBs. Okay, angiotensin aldosterone receptor blockers. And what they do is they block the chemical from binding to its receptor on the cell so it can't work. So one of the main features of this spironolactone is that because it targets sodium, it doesn't actually affect the potassium uptake. So it does allow you to keep the potassium. The reason why this is significant is because in other cases like osmotic diuretics or loop diuretics, when you block sodium reabsorption and your body can't retain the sodium, then that means you are moving sodium out. Whenever you move sodium out, you have to reabsorb potassium because of the NAK pump. It's opposites. So the more sodium you get rid of, the more potassium you're getting. So if you were to take a ton of these kind of loop diuretics, you could become hyperkalemic and become too excessive in the potassium ion. Okay, so altogether, summarizing what we have said before, and this is just a revisitation to one of the lectures that are recorded already, is that the renal system plays an important role for being buffer, and this is just a visual to highlight that there are many ways that hydrogen ions and buffering and pH is attained in the kidneys, right? And so I hope you guys watch the videos. I spent a little bit of time going over some of the buffer systems, but just be aware that when you make your body more acidic, right, it comes from CO2, And oftentimes you can also gain a lot of the protons because you lose it from bicarbonate or all as a result of the amount of food and the way you're breathing. And then the loss of the protons is going to cause your body to become a lot more alkalinic. And so when you vomitus, where you're having a nauseation or you're regurgitating the food products, or if you're losing protons through the ammonia or phosphate, or you're not eating proteins, then you can also trigger your body to become more alkalinic.